Right. Lovely good afternoon to the lovely doctors of this country. A very warm welcome to this afternoon session. Let me just open the group. I think I've not been able to reply some of the WhatsApp messages since 12:20 p.m. If I'm missing out on somewhere, then please do ping me. Though if my message is unread, that means I'm definitely going to have a look at that message as soon as I get time. So I'm now just focusing on our surgery group. Lovely good afternoon, Srinidhi, Pankaj, Puneet. Very good afternoon, Puneet. Right. Vaibhav, Pratmesh, Bhavesh, Aditya, Janvi, Dr. Ashwini, Dhanashri, Jia, Akhil, Sarani. Lovely beta. So lovely good afternoon to all of you. The first thing what we are going to do now is we'll be just revising what we discussed yesterday. And especially in this revision, we'll also be discussing that summary of how to manage these stones, right? Whether it is the gallbladder story or it is the kidney ureter bladder urethra story. So gallbladder, CBD, pancreatic duct, stone disease story, and then kidney ureter bladder urethra stone disease story, right? So first let us revise with the workbook. Herein, in the right hypochondrium in case of adults, we focus on liver, gallbladder, biliary channels, and to some extent the pancreas as well. Now, the commonest problem in adults, surgical problem, is the gallbladder stone. There can be different type of stones forming inside the gallbladder, like pale yellow colored stones. They are cholesterol stones. Green, brown, black, they are pigment stones. Why these stones form? So these stones, cholesterol stones, actually if we are seeing what is coming inside the gallbladder is bile from the liver. And this bile is having cholesterol, bile salt, bile acids. So the balance between the cholesterol and the bile salt, bile acid in the gallbladder does not allow the cholesterol to precipitate and form the stone. But whenever this balance gets disturbed, if the concentration of cholesterol increases, bile salt, bile acid decreases, then the cholesterol will precipitate and form a stone. Such bile where cholesterol is high and bile salt, bile acid is less is lithogenic bile or supersaturated bile. Now, there can be other reasons for cholesterol stones like abnormal enterohepatic circulation. If there are diseases of the terminal ileum like tuberculosis and Crohn's, then what happens? Because we know that whatever bile salt, bile acids, they are going from this bile into the duodenum. When these bile salt, bile acids are reaching into the terminal ileum, 95% are reabsorbed through the superior mesenteric vein, going through the portal vein into the liver. And from the liver, they are again coming through the biliary channels into the gallbladder. So the concentration of bile salt, bile acid in the gallbladder is high. But if the terminal ileum gets diseased like in TB or Crohn's, then this reabsorption will not occur, and then the concentration of bile salt, bile acid in gallbladder will decrease and the cholesterol will precipitate and form the stone. That is how TB and Crohn's can increase the risk of gallbladder stones. Now, pigment stones, that is, pigment is formed due to breakdown of RBC, and majorly the RBC is breaking down in the spleen. So whenever there is more breakdown of RBC, like in hemolytic disorders, hereditary spherocytosis, sickle cell anemia, more pigment will be produced inside the spleen. And this pigment will travel through the splenic vein, portal vein into the liver, and from the liver through the right left hepatic duct, common hepatic cystic, it will be going into the gallbladder. So if there is more pigment here, there will be more pigment here, and this will increase the risk of pigment stones in the gallbladder. Pigment stones can be seen in Bacterial infections like with E. coli, they can be seen in parasitic infestations like Ascaris and Clonorchis sinensis, can also be seen in cirrhosis of liver. Clinically, if there is a stone in the gallbladder, patient can present in different ways. More than 80% will be asymptomatic. Symptomatic can present to us in the OPD or in the emergency. If the patient does not have any problem related to this gallstone, then we might come to know about these gallstones as an incidental finding when the patient is being evaluated for some other problem. Like a 30-year-old lady goes to the hospital for lower abdominal pain. She goes to a gynecologist and gynecologist suspect PID. Then the gynecologist wants to get the ultrasound done. And when the ultrasound abdomen is done, then the lady comes to know that, oh my God, apart from PID, she is having a problem in the gallbladder also. Now, in these patients, ideally the dictum says that nothing has to be done except in those situations where there is some finding which can suggest that this stone can complicate later. For example, if there is a large stone in the gallbladder more than 3 centimeter, it can create acute cholecystitis. Multiple stones in the gallbladder, they can slip through the cystic duct into the CBD and can lead to jaundice. Elderly people, immunocompromised like HIV, already the immunity is down, chances of infection are high. Pregnancy, second trimester, if it is moderate or severe, we do remove the gallbladder if there are stones. Typhoid carriers, again, increased risk of gallbladder cancer because of chronic irritation of the gallbladder mucosa by the salmonella. Porcelain gallbladder, calcium deposition inside the gallbladder, which increases the risk of gallbladder cancer. Adenomatous polyps in the gallbladder more than 10 millimeter in size. Again, chances of cancer would be high. Hemolytic disorder patients and patients who have undergone bariatric surgery, if they are developing gallstones, then even if the patient is asymptomatic, we have to remove the gallbladder. That means laparoscopic cholecystectomy. However, commonly what you are going to see in practice, symptomatic patients who generally come to us in the OPD with mild pain off and on in the right upper abdomen. Clinical examination is not very informative, so you get the ultrasound done, which is the gold standard investigation for gallstone disease, wherein the stone itself appears hyperechoic, and to say that this is stone, we look at the posterior acoustic black shadow. पत्थर पूरे शरीर में कहीं भी हो, अल्ट्रासाउंड करने पे हमेशा अपनी काली परछाई छोड़ते हैं. And we diagnose these gallstones because patient was symptomatic. So we discuss with the patient and plan elective laparoscopic cholecystectomy. In emergency cases, if suppose there is a large stone which is blocking the mouth of the gallbladder, then because there is a complete traffic jam at the mouth of the gallbladder, whatever mucus is inside the gallbladder, that will not be able to come out. So mucus distension of gallbladder is mucocele, stasis party, acute inflammation of the gallbladder, rheuma tumor, calodollar functionalacia, gallbladder will become red, hot, swollen, inflamed. And patient will present with sudden onset of severe right hypochondrial pain, which is radiating to the back, to the inferior angle of right scapula, and sometimes to the tip of right shoulder. Associated with anorexia, nausea, vomiting, and fever type of story. We try to stabilize these patients in emergency, and we do the clinical examination. If we try to insinuate our 4 fingers beneath the right costal margin and ask the patient to take a deep breath, patient suddenly catches her breath. This is Murphy's sign, seen in acute cholecystitis when the gallbladder is red hot. किसी भी लाल चीज को छेड़ोगे तो छोड़ेगी नहीं. So whenever we are touching any red hot inflamed area, the patient is going to wince in pain. Right, this is Murphy's. It is not seen in chronic cholecystitis. We can do ultrasound of the abdomen to confirm, that is the investigation of choice. If there is any doubt on ultrasound that why the gallbladder is red hot inflamed, then we do a HIDA scan. HIDA scan is not the investigation of choice to diagnose acute cholecystitis, but it is to differentiate the cause of acute cholecystitis. Like if it is acute calculous cholecystitis where there is a stone blocking the mouth of the gallbladder, then the isotope, the HIDA, will not be going inside the gallbladder. So there is non-visualization of the gallbladder. But if the gallbladder is red hot inflamed because of acalculous cholecystopathy, acalculous means there is no stone. Why the gallbladder can be red hot inflamed? If there is motor weakness of the gallbladder, that means gallbladder contractility decreases, then the bile which is coming in the gallbladder will not be going out, stasis of bile in the gallbladder, party in the gallbladder, acute cholecystitis. Now in this case, on HIDA scan, the isotope will be going inside the gallbladder, but because gallbladder is not able to contract properly, so whatever isotope has gone inside, that will not be able to come out. So persistence of the isotope within the gallbladder despite washout of the isotope from remainder of the biliary tree, this indicate acalculous cholecystopathy. In these cases, we should also be careful that in acute cholecystitis, whenever there is any acute inflammation going on in the peritoneal cavity, the policeman in the abdomen greater omentum tries to go towards the inflamed organ and tries to envelop the inflamed organ, so that whatever party is going on, that should remain localized in a small area and that should not spread to the general peritoneal cavity. Now, there might be adhesions around the gallbladder, maybe with the omentum or maybe with the transverse colon or the hepatic flexure of colon or maybe with the stomach. In these cases, doing a cholecystectomy can be dangerous. We might cause injury to the surrounding organs. So it is better we admit these acute cholecystitis patient in the hospital, give them IV fluids, IV antibiotics, conservative treatment, let the bacterial party settle down, let the infection be controlled. And once the patient becomes stable, absolutely fine, she start eating normally, maybe 4, 5 days, 6 days, 7 days, then we discharge this patient from the hospital and let the adhesion separate. We call this patient after 3 to 6 weeks and then remove the gallbladder, that is interval cholecystectomy. So asymptomatic, nothing has to be done except in those 10 indications where we have to do a removal of the gallbladder. Symptomatic OPD, elective lap chole. Acute cholecystitis, conservative treatment, interval cholecystectomy after 3 to 6 weeks. In acute cholecystitis, if the patient presents to us within 2-3 days, then adhesions may not have formed and we can remove the gallbladder. When we are doing laparoscopic cholecystectomy, in laparoscopic surgery, we generally make 4 ports. The first port is around the umbilicus, from where we make an incision in the skin subcutaneous tissue and introduce this MCQ needle. This is Veris needle, right? So January 26 also, be careful. This Veris needle can be there in the exam. This is blunt. And here we are putting the carbon dioxide gas. This carbon dioxide gas, which is going into the abdomen, will lift the anterior abdominal wall. We are creating pneumoperitoneum. This will give us the space inside the abdomen to move our instruments. And then we make other ports with the help of visualization through a telescope attached with a camera and make one port in the xiphisternum area or the epigastric region, another small port in the right hypochondrium, another small port in the right lumbar region. And then we do the dissection in the hepatobiliary triangle or the hepatocystic triangle, which is bounded superiorly by the inferior surface of liver, laterally by the body of gallbladder and the cystic duct, and medially by the common hepatic duct. Here, superiorly is the inferior surface of liver, laterally the body of gallbladder and the cystic duct, and medially the common hepatic duct. And the content of Callat's triangle is the cystic artery. Like here you see the content of hepatobiliary triangle is the cystic artery. Cystic artery. Content of hepatobiliary triangle is cystic artery. And there can be cystic lymph node of node which can be sitting here or maybe here. However, Callett's triangle is same as hepatobiliary except superior boundary is formed by the cystic artery in Callett's triangle. Rest everything is same. We do the dissection here and we put two clips on the cystic artery on this side, one clip on this side and chop in between. Two clips on the cystic duct this side, one clip this side and we chop in between. Now, sometimes complications can occur. There is a possibility that during lap chole, sometimes some small stones can slip into the CBD which the surgeon does not recognize at the time of operation. So post lap chole, stones which have slipped into the CBD may create a traffic jam in the CBD leading to proximal dilatation, high pressure. And this high pressure can dislodge the clips on the cystic duct. And if the clips dislodge, bile may start leaking out in the right hypochondrium, subhepatic area. If there is very small amount of bile leak and patient is not having any symptoms post-lap chole, that means the injury is very small and it can heal spontaneously. We just have to do ERCP and put a stent in the CBD. ERCP and stenting, so that bile will come through the lumen of the stent into the duodenum. Bile will not be leaking out and whatever small leak is there, that can close spontaneously. But if there is a huge amount of bile leak in the subhepatic area, significant bile leak, say around maybe 100 cc, 200 cc or something like that, and patient is having problems, pain in the right upper abdomen, maybe fever, in those cases, we cannot allow this infected collection to stay in the subhepatic area because it can spill in the peritoneal cavity, can lead to peritonitis and septicemia and patient can die. So our first duty will be, we do ultrasound guided catheter drainage of this collection. Needless to specify that if patient is having fever, we have to give antibiotics also. But mainstay will be removing the septic load. So ultrasound guided catheter drainage and you remove the collection. You can also do a ERCP and stenting. But because there is a major leak, so that major leak may not close spontaneously and it may require repair later on. So there can be bile leak stories, there can be biliary obstruction by the stones, or sometimes if the surgeon is applying the clips and he is not careful, he might cause some injury in the common hepatic duct here, which on healing can lead to stricture. So biliary strictures can also occur. Now there can be some other pathologies which can be related to the gallbladder, like there can be mucocele, that is mucus distension, empyema gallbladder, pus in the gallbladder. पस को देख के सर्जन को कुछ होता है, पस पूरे शरीर में कहीं भी हो उसे निकालना होगा. If there is localized collection of pus anywhere in the superficial area of the body, we do incision and drainage. If there is localized collection of pus anywhere inside the body, we do ultrasound guided catheter drainage, whether it is empyema thoracis, liver abscess, or maybe localized collection, infected collection in the subhepatic area, or maybe appendicular abscess, pancreatic abscess, or maybe diverticular abscess, or maybe breast abscess. So ultrasound guided catheter drainage. Cholesterosis is also called a strawberry gallbladder, where there are yellowish flakes getting deposited on the mucosal surface of the gallbladder. Porcelain gallbladder is calcium deposition inside the gallbladder, so it will be visible on X-ray and CT scan, and this increases the risk of gallbladder cancer. Mersey's syndrome is jaundice due to compression of the common hepatic duct by a large gallbladder stone. Right. And sometimes we can even find a fistula developing between the gallbladder and the bile duct. Fistula of gallbladder, that is most commonly seen with the first part of duodenum, because a large stone can cause pressure necrosis of the wall of the gallbladder and the wall of the duodenum, and a fistula can develop. If this develops, then this large stone can slip from the gallbladder into the duodenum, and this will be traveling in the duodenum jejunum and in the ileum. It may get impacted in the distal ileum and create intestinal obstruction, which is called as gallstone ileus. Older times, when we were taking X-ray in these situations, we used to find multiple air fluid levels, plus air would have been going inside the gallbladder from the duodenum, and rarely we might see a stone in the intestine. This is called as regular striate. Saint striate is gallstone, hiatus hernia, and diverticulosis of colon. Meckler striate in Bohr-Harvey syndrome, that is vomiting, chest pain, subcutaneous emphysema. Charcot striate, Raynaud's pentad in cholangitis. Charcot's is pain, fever, jaundice. Raynaud's is pain, fever, jaundice, hypotension, mental confusion. Regulus, multiple air fluid levels, air in the gallbladder, stone in the intestine on X-ray. And Saint's, gallstone, hiatus hernia, and diverticulosis of colon. Stone from the gallbladder can slip into the common bile duct and create problems in the common bile duct. Now, this stone can either cause a partial traffic jam in the bile duct, or it can cause a complete traffic jam in the bile duct. If it's a partial traffic jam story, then this patient will come to us in the OPD with intermittent jaundice. We do LFT, we do ultrasound, and to see the biliary channels, the best would be MRCP. But if we have to do any therapeutic procedure or diagnostic procedure, then instead of MRCP, we prefer doing ERCP. For example, if in the exam we have questions where the examiner is clearly mentioning that there is a stone in the bile duct, and now he is asking whether will you do MRCP or ERCP, your answer will be ERCP. But if the examiner is mentioning that patient has presented with jaundice and the ultrasound shows dilated CBD, reason for dilatation of CBD can be anything. So we are not sure whether we have to do any procedure or not. There MRCP would be better. So MRCP and ERCP, this can be done. And the treatment for these CBD stones would be, we just pass the endoscope, then pass a Dormia basket. This Dormia basket can be passed into the CBD, and this CBD stone can be extracted with the help of Dormia basket. Obviously, we will have to do a sphincterotomy first, then we pass this basket and take the stone out. So ERCP sphincterotomy and CBD stone extraction with the Dormia basket. If there is a complete traffic jam type of story, obviously we can understand this will cause proximal dilatation, stasis party, cholangitis, Charcot's, pain, fever, jaundice, sudden severe pain in the right hypochondrium associated with high-grade fever, chills and rigors, and jaundice. If party in the CBD goes into the blood, then patient will land up in septicemia, septic shock, pressure in the pipeline goes down, hypotension, oxygen supply to the brain goes down, mental confusion. In these shock situations, first we focus on saving the life of the patient. First we have to generate pressure in the pipeline so that oxygen can reach to the vital organs. So we have to pump in IV fluids. If it is a significant party, high-grade fever type of story, we have to give IV antibiotics. Try to make the patient stable. If the patient becomes stable maybe in 3, 4, 5, 6 hours, we do a quick LFT ultrasound. And then, because there is a huge amount of bacterial load in the CBD, and this is causing septicemia, patient can die, then we have to do ERCP and stenting, remove that bacterial load from CBD and save the life of the patient. So ERCP and stenting. Here, this is an X-ray picture where we can make out that this stent, what we are seeing, this is most likely probably in the CBD. If the stent would have been something like this, then it would have been in the pancreatic duct. If the stent would have been something like this, then it would be in the ureter. double J stent in the ureter. Right. If suppose the stone slips and blocks the mouth of the pancreatic duct, then there is a possibility if the stone blocks the mouth of the pancreatic duct. Now, because the secretions will stay in the pancreatic duct, it will dilate, there will be premature activation of the pancreatic enzymes within the pancreas, which will start causing necrosis of the pancreas, and that is acute pancreatitis. Most common cause of acute pancreatitis is gallstones. Second most common cause is alcohol, children, hereditary causes and trauma, and operative cause of acute pancreatitis is ERCP. Whenever we are doing sphincterotomy, there can be reflux of duodenal contents more into the pancreatic duct causing acute pancreatitis. Sometimes they can even reflux into the bile duct and may rarely cause cholangitis also. Now, in acute pancreatitis, patient will present with sudden severe upper abdominal pain radiating to the back either from the right side or from the left side. This pain will be aggravated in supine position, but it will be relieved on sitting and bending forwards. There will be anorexia, nausea, vomiting type of feature. Fever is not an early feature in acute pancreatitis because it is not a bacterial party, it's an enzymatic party. However, when the pancreatic necrosis is taking place, that necrotic tissue may invite secondary bacterial infection, and then patient will develop fever, and then will come the role of antibiotics. In acute pancreatitis, when this enzymatic necrosis is going on in the retroperitoneum, the peritoneum and the other secreting surfaces in the body start throwing lots and lots and lots and lots and lots and lots of fluid to neutralize this party. There is huge amount of fluid loss from the pipeline into the third space, which will lead to fluid collection here and there, maybe in the retroperitoneum, maybe in the peritoneal cavity ascites, maybe in the pleural cavity pleural effusion. And because of huge amount of fluid loss, volume in the pipeline goes down, pressure in the pipeline goes down, oxygen supply to the vital organs goes down, patient may die. There would be tachycardia, tachypnea, and hypotension type of story. One more thing, if enzymatic party is going on in the pancreas, it is not only the pancreatic tissue which is getting necrosed, but even the small blood vessels in the pancreas would be getting necrosed, and bleeding would be happening in the retroperitoneum. And this blood can trickle and come anteriorly, and we may find bluish discoloration in the flank area, that is Gray Turner sign, bluish discoloration around the umbilicus, that is a Cullen's sign, bluish discoloration in the inguinal region is a Fox sign, and further down it is the Bryant sign. How to approach these patients? As we can understand that the patient might be in shock. So if the pressure in the pipeline is less, oxygen supply to the vital organs is less, we have to generate pressure in the pipeline by pumping in IV fluids. This is going to save the life of this patient. So IV fluid will be the most important first thing to be done in the management. No role of prophylactic antibiotics initially. If later patient develop fever, then we give antibiotic. Initially, when you are trying to stabilize the patient and you are suspecting acute pancreatitis, you quickly get the pancreatic enzymes assessment done, serum amylase and serum lipase. Amylase start rising immediately in acute pancreatitis and it remains elevated for 3 days. But amylase can rise in various other acute abdominal conditions like acute cholecystitis, perforation peritonitis, mesenteric ischemia, so we cannot rely on amylase. However, if the value of serum amylase is more than 3 times the normal, then it favors the diagnosis of acute pancreatitis. Serum lipase is specific for acute pancreatitis, and Problem with lipase is it starts rising after 3 days, though it remains elevated for 12 days. So generally, we are getting the information about acute pancreatitis by these enzymes. In olden days, when we used to do X-ray, then we used to find some signs in acute pancreatitis on X-ray: colon cutoff sign, sentinel loop sign, and renal halo sign. If we are in doubt after pancreatic enzyme assessment, then we can do CT scan, which can even grade the severity of acute pancreatitis, Balthazar grading. And this is the radiological investigation of choice, but it is not routinely done because without a CT, we are able to make the diagnosis many a times. Once the diagnosis is there, patient is stabilized. Now, to treat acute pancreatitis, if we remove that stone which was blocking the mouth of the pancreatic duct, all the pancreatic enzymes will start flowing through the pancreatic duct into the duodenum, and that enzymatic party in the pancreas will subside. And to remove this stone, a simple method, we do ERCP, sphincterotomy, and stone extraction with the Dormia basket. That means ERCP can be a cause of acute pancreatitis also, and ERCP is the treatment for acute pancreatitis also. Surgery is generally not required in the management of acute pancreatitis. However, specific indications for surgery include if there is abscess around the pancreas, then we do percutaneous drainage of these abscess through a catheter under ultrasound or CT guidance. Sometimes we might have to do surgical intervention in pseudocyst of the pancreas. Pseudocyst is if for any reason, if the mouth of the pancreatic duct remains blocked, then the enzymes will not be able to go into the duodenum. Pancreatic duct will dilate, high pressure, and the duct can rupture, and there will be leakage of enzymes around the pancreas. This will be neutralized by the fluid around, and there is collection of enzymes and fluid around the pancreas. Because it is not lined by any true epithelium, so it is not a true cyst, it is a pseudocyst. Usually, if the traffic jam at the mouth of the pancreatic duct is clear, then whatever collection is taking place outside the pancreas, that collection will come into the duct on its own, and this collection will go into the duodenum. So generally pseudocysts are small, patients are asymptomatic, and they resolve spontaneously. It is only in those situations when the mouth of the duct remains blocked. Then these collections keep on increasing, and in those situations, these pseudocysts can become very large. They can extend up into the mediastinum and down up to the pelvis. There is a risk stasis infection, abscess formation, they can rupture. Malignancy is never seen in pseudocyst because there is no epithelium. Investigation of choice for these pseudocysts would be a CT scan. Like here we are seeing a nice big pseudocyst. If the pseudocyst is causing any symptoms or complications for the patient, and if it is present for more than 12 weeks, then we need to do some or the other treatment for the pseudocyst, because the pseudocyst is having enzymes and fluid, and these enzymes are supposed to go into the intestine. So instead of doing an external drainage, we prefer doing a internal drainage. That means we just connect these pseudocysts somewhere in the intestine, maybe stomach, duodenum, or jejunum. Generally, we are doing a cystojejunostomy. We can also do a cystogastrostomy. Because there is very high mortality risk in acute pancreatitis, so as the great doctors of this country, you need to quickly analyze and understand that how aggressive you have to be in managing these patients, and you can explain the same prognosis to the attendants of the patient as well. because in severe necrotizing pancreatitis, the mortality rates can be as high as 50%. So it's very important to calculate these prognostic scores as quickly as possible. Like a quick SOFA score can be calculated, which comprises of measuring three things: respiratory rate 22 or more than 22 per minute, systolic blood pressure 100 or less than 100 millimeter of mercury, and altered mental status where the GCS is less than 15. If two or more than two of these are present, then it indicates significant sepsis and the mortality rates would be very high. The detailed SOFA score, sequential organ failure assessment score, comprises of analyzing the 6 systems in the body: CNS, CVS, respi, liver, kidney, and hemat. Each system is given a score of 0 to 4. Other prognostic scores which can be used are Apache 2 score, Renson score. Mortality in mild acute pancreatitis is less than 1%. In severe necrotizing pancreatitis, 20 to 50%. So the gallstone story we have seen nicely. When the stone was in the gallbladder, how to play the game. When the stone came in the CBD, how to play the game. And when the stone came in the pancreatic duct, how to play this game. Now, chronic pancreatitis is commonly seen in smokers, alcoholics, because they tend to remain dehydrated. So secretions of different glands in the body, they lose water and they become thick. And when thick secretions are traveling in the duct, these thick secretions can create partial traffic jams at multiple places in the pancreatic duct. Chronic pancreatitis is actually irreversible pancreatic cellular atrophy associated with calcification, ectasia strictures in the pancreatic duct. We can understand that if there are partial traffic jams at multiple places in the pancreatic duct, the proximal pupil will dilate. So, this is not a one-day story, this is a long story. And this is going to cause back pressure on the pancreatic cells. Both exocrine cells and endocrine cells will face the pressure. And because of this back pressure for a long period of time, these pancreatic cells will start undergoing atrophic changes. If the exocrine cells are getting atrophied, enzyme production will decrease and patient will suffer from malabsorption. If endocrine cells are getting affected, 75% are beta cells. So insulin production will decrease and this will lead to hyperglycemia or diabetes mellitus. Another thing, whatever exocrine cells are working, they will produce the pancreatic enzymes and this will be produced more after meals. So when these pancreatic enzymes are coming into the dilated portions of the duct, especially after meals, this may create congestion within the pancreas, which causes epigastric pain after meals. This chronic pancreatitis is 4 times more common in males and it is seen after 40 years of age with 3 presentations: epigastric pain aggravating after meals, malabsorption, and diabetes mellitus. When we do MRCP, ERCP in these patients, the dilated and narrow portions, they appear like chain of lakes appearance in chronic pancreatitis. In the treatment for malabsorption, we give pancreatic enzyme supplements like pancreatoflat and creon. For diabetes mellitus, we give insulin. And for relieving the pain in chronic pancreatitis, we ask the patient to abstain from alcohol, don't take bulky meal, take small frequent meals. We can give analgesics, octreotide before meals. If all this does not help, then the last resort is surgery, where we have to communicate the dilated portions of the pancreatic duct with the jejunum. That is basically a side of the pancreatic duct to the side of the jejunum. So this is side to side pancreaticojejunostomy or a longitudinal pancreatic jejunectomy, which is modified post-dose operation for chronic pancreatitis. Apart from this story of gallbladder, bile duct, pancreas, there can be something inside the liver like liver abscesses, which can be pyogenic, amoebic, or hydatid cyst. Pyogenic means bacterial party, amoebic protozoal entamoeba histolytica, and hydatid cyst parasite Echinococcus granulosus. Pyogenic, commonly the bacteria responsible, Streptococcus miller and E. coli. Now, we can understand if there is cholangitis, party in the bile duct, this party can go up in the liver and can cause pyogenic liver abscess, which can be single or multiple. And in pyogenic, because it's a bacterial game, so patient will have high-grade fever, chills, rigors, and a high risk of septicemia. Patient may be experiencing pain as well in the right hypochondrium and sometimes even jaundice. Amoebic liver abscesses, when the patient takes the amoeba through the fecal-oral route, these amoeba, they love two areas in GIT, the cecum and the sigmoid colon, where we can even find inverted flask-shaped ulcers in the sigmoid colon in amoebic colitis. So whether it is the cecum area, that is midgut area, or it is the sigmoid hindgut area, this entamoeba story can travel through the superior mesenteric or the inferior mesenteric vein. And from here, this story travels through the portal vein. The right branch of portal vein is going straight to the posterior lobe of liver, right posterior lobe of liver. That is the segment 7 of liver. That is why amoebic liver abscesses are commonly seen in segment 7 of liver. Hydatid cyst, that is Echinococcus granulosus, again a fecal-oral transmission, and if this hydatid story also goes from the midgut hindgut area through the superior inferior mesenteric vein into the liver, it can form a cyst inside the liver. Usually amoebic liver abscess and hydatid cyst are single and both can present with pain or maybe jaundice or sometimes even fever. Now, if a patient is complaining of pain in the right hypochondrium, we can do a ultrasound of the abdomen. If the patient was having jaundice, we can do the LFT. LFT ultrasound are almost complementary to each other in the right hypochondrium. And on ultrasound, we can see that there is some cyst developing inside the liver or some collection inside the liver. Better than ultrasound would be CECT to see these liver abscesses. In case of hydatid cyst, when we are doing ultrasound or CT, we can see a water lily sign as well in hydatid cyst. Now, there is a Garby classification where we can even do the grading of these hydatid cyst. If it is only a liquid component inside, it is grade 1. If we find a floating germinal epithelium, water lily sign, this is grade 2. If there is a honeycomb type of appearance, this is grade 3. If there is heterogeneity, then this is grade 4. And if it has become calcified, then it is grade 5. So that is how we can grade these hydatid cysts on ultrasound or CT scan. That is Garby classification. If suppose we are just seeing a cyst like this on ultrasound or CT, we might get confused whether it is a pyogenic, amoebic, or hydatid. If we have to confirm the diagnosis, then we can do a blood culture or pus culture, and that will give us the information about pyogenic nicely. We can do a stool test, and if we are able to identify the cystova of entamoeba, that is amoebic. If we do a blood test ELISA, where we detect antibodies against the hydrated antigen, then it will be hydrated cyst. And based on our diagnosis, we will give the treatment accordingly. If it is pyogenic bacterial story, then we have to give aggressive IV antibiotics targeting gram positive, gram negative, and the anaerobes like cephalosporin penicillin, aminoglycosides, and metronidazole. In amoebic, we give metronidazole almost in double doses, that is 400 to 800 milligram thrice a day for 14 days. And if it is hydrated, we give albendazole, mebendazole. If the abscesses are large and there is risk of rupture of these abscesses, so before the rupture, we should drain these abscesses, and as all the great doctors know, localized collection of pus anywhere inside the body, we do ultrasound guided catheter drainage. Here we use a pigtail catheter to drain these liver abscesses. When we are draining amoebic liver abscess, then we find a chocolate colored pus, that is anchovy sauce pus in amoebic liver abscess. In hydrated, when we are draining them, we have to be extra careful, because if there is any live activity in the cyst and when we are aspirating, then we might spill them around the liver, which can disseminate or spread the disease. So we use a special technique, pair, where we do a percutaneous aspiration, then instill hypertonic saline in the cyst to destroy any live activity in the cyst, and then we do the reaspiration. Sigmoid volvulus, though sigmoid colon we know it is in the left iliac fossa, but if there is long axis of mesentery of the sigmoid colon, it can rotate in an anti-clockwise manner so that the apex of sigmoid comes towards the right hypochondrium. And when we take the X-ray, we find a classical coffee bean sign in sigmoid volvulus. We can even see a bird of prey sign in sigmoid volvulus. In the treatment, we just leave a flatus tube in the sigmoid colon for 24 hours, and this will derotate. This will empty the sigmoid colon, and then sigmoid colon will derotate on its own, will come back in the left iliac fossa, and nothing is required. But if suppose because of this volvulus, the blood supply to the sigmoid colon has gone and sigmoid colon looks to be strangulated or gangrenous, then we need to do resection of this gangrenous sigmoid colon and anastomosis. Like this is another picture where we can see this is the classical coffee bean sign. If we look at the lumbar region, about the urinary stones. Now, urinary stones, they can occur anywhere in the kidney, ureter, bladder, urethra. The most common kidney stone is calcium oxalate dihydrate, whether it is adults or in children. However, most common urinary bladder stones, especially in boys or children, it is calcium oxalate and ammonium urate. Urinary bladder stones are 10 times more common in boys. In case of adults, urinary bladder stones can be of uric acid. Why these stones form in the urinary tract? The commonest reason is idiopathic hypercalciuria. More calcium excretion in the urine, calcium will get deposited anywhere in the urinary mucosa, and gradually crystals will get deposited, and that can form a stone. Idiopathic hyperoxaluria, hyperuricosuria, cystinuria, prolonged immobilization where the peristalsis slows down, so the chances of stasis are there. Infection, urinary tract infection can occur. Cranberry juice somehow prevents UTI. Deficiency of vitamin A, hyperparathyroidism, milk alkali syndrome, all this can lead to more calcium excretion in urine. The different type of stones we come across in the urinary tract, calcium oxalate being the most common, can be monohydrate or dihydrate. Dihydrate is the most common, monohydrate is the second hardest stone. And these stones are spiculated, spiky, So the chances of hematuria are high. Patient passes these envelope crystals in urine. Triple phosphate stones composed of calcium, ammonium, magnesium phosphate, which is called as the Stru-White stone, and they are seen in alkaline urine, especially when the urine is infected with urea splitting organisms like Proteus or maybe Klebsiella. These triple phosphate stones generally remain silent. They can take the shape of pelvic ileal system, and such stones are called as staghorn stones. Staghorn stones. Cystine stones, they are hardest stones and they're difficult to be broken by shock waves, commonly seen in patients with cystinuria, and we can find benzene hexagonal crystals. Uric acid stones are seen in uricosuric patients in acidic urine, and because they do not have calcium, they are not seen on X-ray, they are radiolucent. Those stones which are not seen on X-ray in the body are remembered by the mnemonic PG Lux. PG में जाएंगे, Lux से नहाएंगे. P for parotid duct, G for gallbladder. Lux is lysine, uric acid, and xanthine urinary stones. Other stones can be xanthine, lysine, indinavir, triamterene, allopurinol type of stones. The presentation of urinary stones. Commonly, these patients come to us with pain. However, frequency of micturition, hematuria, and in large bladder stones, there can be interruption of urinary stream as well. The location of pain depends on the site of stone. If suppose the stone is in the kidney, then there is a fixed lumbar pain. If the stone is in the upper ureter, the lumbar pain radiates to the perineum in females and testis in males. If the stone is at the junction of upper and middle ureter, that is at the pelvic brim, then the lumbar pain radiates to the inner thigh. If the stone is in the middle ureter, then the lumbar pain radiates to the iliac fossa. Like right middle ureteric stone will mimic acute appendicitis. If it is a lower ureteric stone, then patient has got strangury, that is painful desire to pass urine with passage of just few drops of urine, rarely blood. If it's a bladder stone, then patient has suprapubic pain. And if the bladder stone comes at the bladder neck or in the urethra, then suprapubic pain is referred to the tip of penis. When these patients come to us in emergency, they are in severe pain. Generally, we know that we should not give the painkillers in patients unless our clinical diagnosis is completed. But these urinary stone patients are in so much of pain that they will not even allow clinical examination. And clinical examination may not be conclusive also. So first we have to make these patients stable and we give analgesics like diclofenac or tamsulosin. Once the patient becomes stable, because 80 to 90% of urinary stones have calcium and they are seen on X-ray, so we can do a plain X-ray of kidney, ureter and bladder. You are not seeing any contrast whatsoever, so this is a plain X-ray where you are seeing a hyperdense shadow, probably a staghorn stone in the left kidney. This is an image where you are seeing a bladder stone in the bladder like this. If you are not able to see the stone on X-ray, or if suppose ultrasound facility is present right there, then you can do ultrasound of kidney, ureter and bladder as well. However, the best investigation to see the urinary stones or the investigation of choice for the urinary stones will be non-contrast CT scan. Remember, for urinary stones, do not give the contrast because contrast and stone have got the same density. If you give the contrast, you may not be able to see the stone. So non-contrast CT will show the stone nicely. Once the diagnosis is made, then comes the treatment part. Now treatment part, because we know that the diameter of ureter and diameter of urethra is 6 to 8 millimeter. So any stone which is less than 5 millimeter or up to 5 millimeter in size does not require any intervention, and this will pass spontaneously in urine. 90% of stones up to 5 millimeter in size pass spontaneously in urine. Stones 6 to 10 millimeter in size, 50% of these stones can also pass spontaneously in urine. However, if the stone is bigger than 5 millimeter, depending on the location of the stone, we can plan the treatment accordingly. The least invasive, or you can say the non-invasive method to treat the urinary stones is extracorporeal shock wave lithotripsy. So whether the stone is here, or the stone is here, or the stone is here, we can fire the shock waves, break the stone into small fragments, and those fragments will pass spontaneously in urine. So ESWL becomes the treatment of choice for urinary stones which are more than 5 millimeter in size, unless there is some contraindication of ESWL. Like, we cannot do ESWL in the pelvic area because of risk of damage to the pelvic organs by the shock waves. Pregnancy, we should not use ESWL. However, bigger stones, more than 2 centimeter in size, should not be broken with ESWL. Because if the size is big and you try to break it, the fragmented stone may also be bigger in size, bigger than 5 millimeter, which can get stuck. You may have an argument that we can repeatedly fire these shock waves and we can break even those larger fragments. But remember, these shock waves do cause damage to the tissues. So it's not that you keep on firing these shock waves continuously. Otherwise, it will definitely cause damage to the tissues. So we have to be careful. If the patient is having any bleeding disorder, then also ESWL is avoided, because there will be chances that when the stone is fragmented, the fragmented stones can injure the urothelium and cause bleeding. And if patient is having any bleeding disorder, this bleeding may not stop. If there is any distal obstruction, say a stricture in this area, then also you should not do ESWL, because the fragmented stones will get arrested here only. Whenever we are breaking these stones by ESWL, like here you see, the shock waves are fired directly onto the stone and the stone is broken into small fragments. These fragmented stones align themselves in the ureter like a street of stones, which is called as Steen-Strass phenomena. Steen-Strass phenomena. And these fragmented stones will pass spontaneously in urine. Most common complication of ESWL is bleeding. Now, if suppose there is a kidney stone which is less than 2 centimeter in size, and still if we cannot do ESWL, like in patients who are obese, in patients who are having musculoskeletal disorders, obese patients, the shock waves will have to travel through a big area, and the depth of shock waves, if the stone is situated at a deeper location, shock waves may not reach to the stone. So we have to be careful in obese patients. Similarly, musculoskeletal disorder patient, a patient who cannot lie supine and still, or patient who is having bleeding disorder, or if there is a stone which is located in the lower calyx. Now, what is this lower calyx basically? If suppose this is the game, if I say beta, there is a stone here or there is a stone here, and you fire the shock waves, this stone will be broken and these fragments can easily come here. But if there is a stone in the lower calyx and if you fire the shock waves, there is a possibility that the fragmented stones may remain in this area only. So in such cases, we can do a RIRS, retrograde intrarenal surgery. We can go here, fire some energy like laser, maybe holmium laser or carbon dioxide gas, break the stone, and then we can remove these stones with a basket. So retrograde intrarenal surgery can be done for less than 2 centimeter stones if ESWL is not possible. If it is a big stone, more than 2 centimeter in size, then we do PCNL, that is percutaneous nephrolithotomy, where we make a cut on the skin, create a track up to the renal pelvis, pass a endoscope, that is nephroscope, and this nephroscope goes to the renal pelvis. Then we can fire some energies like laser or carbon dioxide gas, break the stone, take the fragments out with the help of Dormia basket. So that is what we can do. However, if we are talking about ureteric stones, now if the stone is in the ureter, say in this area or maybe in this area, then we have the option of passing a ureteroscope into the ureter, and through the side channel of this ureteroscope we can pass a Dormia basket and we can extract this stone with a Dormia basket like this. This is ureteroscopic retrieval of stone. If there is a stone in the bladder, then we pass a cystoscope, and through the cystoscope we pass some instrument from which we can fire the energies like laser or carbon dioxide gas, break the stone into small fragments, and let the patient pass these small fragments in urine. If the stone is in the urethra, then you use an endoscope, push the urethral stone back into the bladder and treat it like a bladder stone. So that is the whole summary how we treat the different stones in the entire urinary tract, right? If there is a stone in the kidney and it is up to 5 millimeter in size, plenty of fluids. If it is more than 5 millimeter in size, up to 2 centimeter in size, first option ESWL. If ESWL not possible, then retrograde intrarenal surgery. If the stone in the kidney is more than 2 centimeter, then PCNL. If the stone is in the upper ureter, then we can do ESWL. If it is in the middle ureter, we can do ESWL. If ESWL is not possible, then we do ureteroscopic retrieval of stone. If the stone is in the lower ureter, we cannot do ESWL, so we do ureteroscopic retrieval of stone. If the stone is in the bladder, then we do litholapexy. And if the stone is in the urethra, then we push the stone back into the bladder and treat it like a bladder stone. Right. PCNL can have its own complications. PCNL is done through 12th rib approach posteriorly, so there is risk of injury to the pleura, as the lower border of pleura posteriorly is at 12th rib level. And if we are injuring the pleura, there will be chances of hemothorax and hydrothorax. Most common complication of PCNL is bleeding because we are going through the renal parenchyma. Sometimes in PCNL, we might cause injury to the colon. We might cause injury to the spleen if we are doing a left-sided PCNL. Injury to lungs is not usually seen in PCNL. Whenever we are doing any endourological procedure, wherein whether we are doing a URS or retrograde intrarenal surgery or ESWL or PCNL, that means whenever we are doing endourological procedure in the upper urinary tract, not for bladder urethra, but ureter kidney story, जब भी यूरेटर किडनी में कोई कार्यक्रम कर रहे हैं तो इट इज इम्पॉर्टेंट टू लीव अ डबल जे स्टेंट इन द यूरेटर so that whatever stone is there in the kidney or ureter, when you are breaking it, these fragmented stones can align along the DJ stand and come down in the bladder. They should not remain impacted in the ureter. They should not create traffic jam in the ureter. And whenever this double J stent is put in the patient, on X-ray, this double J stent can be seen somewhat like this in the ureter. Because it's a foreign body, it can create foreign body reactions and complications later on. So these double J stents should ideally be removed within 3 to 4 weeks time, or sometimes even up to 6 weeks. And it is very simple to remove these DJ stents. We have to just put a cystoscope in the bladder, pass a biopsy forceps through the side channel of the cystoscope, hold this J loop of the DJ and retrieve the entire assembly out. That is how these DJ stents can be removed within 2-3 minutes from the bladder with the help of cystoscope. Sometimes there may be emergency urinary obstruction, for example, depending on whether it is the upper tract or the lower tract. Suppose there is an obstruction in the upper tract and the proximal people are dilated, hydroureteronephrosis, stasis party, pyonephrosis type of story is there, then we try to pass a double J stent from below through the cystoscope. Actually, we take the cystoscope into the bladder. Through the side channel of the cystoscope, we pass this double J stent, try to negotiate it through the ureteric opening, take it in the ureter. If we are able to pass the DJ across the obstruction, the game is over, because now the urine or the pus, whatever it is in the proximal part, that will come through the lumen of DJ into the bladder, and from the bladder it will be going out. So this is called as endourinary stenting. If we are not able to pass the DJ across the obstruction, then if the proximal system is dilated and there is stasis party type of story as well, we do a PCN, percutaneous nephrostomy. If the game is played in the lower urinary tract, like there is obstruction in the urethra, we can try passing a Foley's urethral catheter and relieve the urinary retention through a Foley's catheter. If we are not able to negotiate this Foley's across the obstruction and there is a distension of the bladder, retention of urine, then we can do a suprapubic cystostomy with a supracath. Urinary tuberculosis, it is not that common. It is not a ascending infection. It is a hematogenous infection wherein mycobacteria would be coming from the lungs towards the kidney. And initially, the damage starts at the renal papilla, papillary ulcer. Gradually, it can involve the entire kidney, putty kidney, cement kidney, and the cement kidney can break, autonephrectomy. This mycobacteria will be traveling down through the ureter because there is continuous peristalsis in the ureter. So chances of mycobacteria staying in the ureter are less. So ureteric TB is less. In the bladder, they settle around the ureteric opening and may cause something to the ureteric opening, that is Goldfold ureteric orifice. If this party involves the entire bladder, healing fibrosis, the bladder may become narrow and contracted, which is called as thimble bladder. If there is party going on in the kidney or maybe in the bladder, this will be irritating the urinary mucosa and patient will have frequency of micturition. There can be hematuria, there can be anorexia, weight loss, low-grade evening rise of temperature, which are the constitutional symptoms in TB. Whenever you are suspecting UTI, you do a early morning midstream urine sample analysis. In TB, there will be a lot of pus cells or bacteria in urine. The pH will be acidic, but when you culture this, mycobacteria will not grow in 24 to 48 hours. So urine culture will be sterile. Sterile acidic pyuria is an important feature in urine examination. which gives us a clue that patient might be suffering from urinary tuberculosis. Best would be get the CCT done, or you can do some gold standard investigation for tuberculosis. If we are doing a CCT or IVP, in the initial stages of renal tuberculosis, we find moth-eaten calluses or indistinct calluses, and in the late stages, we find a pseudocalculi appearance. In case of bladder TB, initially we find a goal-fold ureteric orifice, and late stages we can find this thimble bladder. And the treatment for urinary TB will be ATT, anti-tubercular therapy. Right, beta. Now, I'll just check the WhatsApp group, and I would just like to know from all of you, Pushkar, classification of Merezi syndrome has not been asked in the FMG exam till now. However, Bismuth-Strasberg classification for biliary stricture has been asked in the NEET PG exam few years back. Prathamesh, sphincterotomy, partial obstruction can cause influx of yes. I hope, beta, we are able to get a nice clarity, and congratulations to all the great doctors. You are more than 1000 now. Wow, lovely. Yes, Vidyat. In acalculous cholecystopathy, what if we don't remove gallbladder and he is doing normal for years? Nothing doing, beta. When we are doing a HIDA scan, if we go into a little detail, it is the ejection fraction which matters. If the gallbladder is able to pump more than 35% of bile, then the chances of stasis will be less and we can leave the gallbladder as such. Dash. Sir, if we know already that there is stone in the ureter causing hydronephrosis, so why we need to put digestant? Can't we directly remove the stone? Whenever there are complete traffic jam situations, generally the patient might be having some hemodynamic instability if it is complicated, like it is not hydronephrosis, suppose it is pyonephrosis. Then we do not want to increase the length of the procedure for anesthesia. Otherwise, those anesthetic agents going into this patient who is already in almost a difficult state might be a disaster. So we do minimal intervention and try to derive the maximum output. That is not the definitive management, that is just the emergency treatment. Definitive management has to be done later on, but yes, practically speaking, when we are trying to put a DJ stent, see, DJ stent can be put under local anesthesia also, but if you have to break the stone, then patient will require complete anesthesia. During pregnancy, beta, we can go for other options. We will not do ESWL, we can go for URS. For this, we'll do URS or RIRS. Pregnant female, 12 millimeter stone. Where was that? Oh my God. I think I am opening another question. This 40-year-old high-grade fever, abdominal pain, hepatomegaly, liver dullness. High grade fever, nothing else specified, pyogenic. Any traveling history given, then we can think of some other diagnosis. But a PCNL is not usually done in pregnancy. In pregnancy, basically we try to be as less invasive as possible. एक मुद्दे की बात बिल्कुल क्लियर होनी चाहिए. एक तो प्रेगनेंसी में फीटस है, रेडिएशन एक्सपोजर अवॉइड करेंगे जितना हो सकेगा. दूसरा, ट्राइमेस्टर पे डिपेंड करेगा. अगर मान लो पेट फूल रहा है तो ऑब्वियसली स्ट्रक्चर्स भी पीछे पुश होंगे, तो कोई भी इन्वेजिव जो चीज़ है वो दिक्कत दे सकती है. तो रेडिएशन का ध्यान रखना है. एनेस्थीसिया में जो दवाइयाँ दे रहे हैं उससे नुकसान हो सकता है, उसका ध्यान रखना है. और जो एब्डोमेन में स्ट्रक्चर्स पे कंप्रेशन हो रहा है उसका ध्यान रखना है. तो वील ट्राई टू बी एज लेस इन्वेजिव एज पॉसिबल इन प्रेग्नेंट लेडीज एज फार एज यूरिनरी स्टोन्स आर कंसर्न. Like we know that ESWL we are not going to do, or any radiation exposure like PCNL will require huge amount of radiation, so we'll avoid that. If the story is related to ureteric stone and suppose he is giving you an emergency story like it's a complete ureteral obstruction, then follow the least invasive procedure which require least anesthesia. For example, you can do stenting. Endourinary stenting would be a better option. But if you have to remove the stone, then URS can be done under spinal anesthesia. So you can opt for URS. If URS is also not there, then I don't think, because there is no other least invasive method which is available. Whenever you have to give anesthesia, try to prefer second trimester of pregnancy. Avoid first and third trimester. This is a general statement. Any operation which can be done without general anesthesia, say spinal anesthesia, yeah, we can go ahead. Any procedure which can be done under local anesthesia, wonderful, perfect. Right? This is, we are talking about pregnant females. Okay. भैया एफएमजी सॉल्यूशन में ना वो ट्रैवलर डालना भूल गए हैं, इसलिए उन्होंने आंसर वो दिया है. ठीक है नहीं बेटा? चलिए. सो एक मिनट सर. हाउ टू मैनेज एक्यूट पेनक्रेटाइटिस? द कॉज इज अल्कोहल नॉट गॉल स्टोन. विल डू ERCP. See, generally alcohol reason for acute pancreatitis in alcoholic patient, it is more acute on chronic pancreatitis. That means patient was having some chronic pancreatitis story and now suddenly there is a complete obstruction somewhere in the duct and that is causing a complete traffic jam and that is causing acute pancreatitis. In these cases, we can do ERCP and we can try to figure out where is that complete obstruction. Suppose that complete obstruction is close to the ampulla vater. Then we can try removing that obstruction. We can try clearing those clogged secretions. And if we are able to open the duct, the acute story will settle down. So that is one possibility. However, if not, then we just try to manage the acute condition with the help of supportive treatment. And then once the patient becomes absolutely stable, and because we are not able to put a stent also, we are not able to clear the secretions also through ERCP, then we are left with no choice, but we might land up in doing that longitudinal pancreatic vaginectomy if it is a alcoholic acute on chronic pancreatitis. Yeah, Pushkar, basically MRCP is done. MRCP is the first line investigation if it is not if it's a pathology related to bile duct or pancreatic duct and it is not a small baby. ठीक है, छोटे से बच्चे में MRCP अपन नहीं कर पाएंगे. अगर CBD डायलेटेड है बेटा जी या पैनक्रियाटिक डक्ट डायलेटेड है और अपने को कारण नहीं पता, वी डोंट नो द रीजन व्हाई दिस CBD और पैनक्रियाटिक डक्ट इज डायलेटेड, तो we go with MRCP. But if we have got some obvious cause, some tumor type of story where we think yeah, we can take a biopsy, so we prefer doing ERCP. If there is a stone, we have a chance that we can remove these stones. So we go with ERCP in those situations. Vivek, beta, adult surgery revision part not added in revision. It will not be deleted. The team will be trying to extract it, I'm pretty sure. Sir, if the pus and stone at same location in gallbladder, what is the procedure we need to do first? Doctor answer. Beta ji, if you don't mind it, I would like to hear from you only. अगर पस और पत्थर दोनों वहीं पे हैं तो पहले क्या करेंगे? पत्थर को निकालेंगे या पस को ड्रेन करेंगे? माना बिट्टा आप पूछ रहे हैं डॉक्टर आंसर, लेकिन आई वुड लाइक टू नो फ्रॉम यू. एक मिनट. ड्रेनेज, लवली बेटा. लेट मी क्लैप फॉर यू डॉक्टर आंसर. दिस इज व्हाट आई वांटेड बेटा. गेम ऐसे ही खेलनी है. परफेक्ट, एब्सोल्युटली करेक्ट, बहुत बढ़िया, छा गए बेटा. क्योंकि हिंदुस्तान के इतने बड़े डॉक्टर्स जो आज इस व्हाट्सएप ग्रुप में इंटरेक्ट कर रहे हैं, यस पुनीत, ऋतिका, आकाश, युक्ति, VRK, इशिता, एवरीवन, विभोर, बहुत बढ़िया. अगर ये कॉन्सेप्ट बैठ गए ना बेटा तो फिर तो गेम बहुत आसान हो जाएगी, क्योंकि यहीं तो फंसा रहा है वो. वॉट एवर इज रिटन इन दी वर्क बुक, वो तो आप इतना बुरी तरह घोट डालोगे ना, चूरन चटनी बना के, काढ़ा बना के उसको पी जाओगे. दिस आई एम प्रेटी श्योर. लेकिन मैं यही चाहता हूँ बेटा कि ये जो फोड़ रहे हो ना आप लोग, ये जो सोच रहे हो, ये खेलने का तरीका सिखा रहा है. एंड दीज आर द क्वेश्चंस वेयर द एग्जामिनर इज ट्राइंग टू ट्रैप यू. एंड दिस इज व्हाट आई वांट कि बस जब अपने को दिख रहा है भाई, अगर उसकी जान जाने का खतरा है तो अपने को पहले जान बचानी है ना. पत्थर पुत्थर तो निकल जाएगा यार, पत्थर को तो बाद में देखेंगे, पत्थर का क्या है. एंड यू ऑल आर एब्सोल्युटली करेक्ट. चलो बेटा, अब एक काम और करते हैं छोटा सा. पवित्रा, इफ यू हैव स्टिल दिस क्वेश्चन देन माय आंसर इज URS फर्स्ट. यस, एक मिनट, ये वो शायद थोड़ा लास्ट, ये क्वेश्चन है कहाँ जो मेरे को नहीं मिल रहा है. सर URS में अगर 12 मिलीमीटर का स्टोन है तो हाउ विल इट बी रिमूव्ड यूजिंग डॉर्मिया बास्केट? बेटा वी कैन फायर कार्बन डाइऑक्साइड गैस ना नीचे से. क्या करते हैं अपन आंचल कि इफ दिस इज अ ट्यूबुलर स्ट्रक्चर, ठीक है, वी टेक द यूरेट्रोस्कोप वेरी क्लोज टू द स्टोन and then through the side channel of the ureteroscope we can put a wire type of thing. Now I'll tell you lithotripters. Lithotripters are something which can break the stone, and there are different energies available. Like there is a mechanical lithotripter, there is a pneumatic lithotripter. Mechanical means we take a wire type of thing through that ureteroscope, keep the tip of the wire on the stone, and then we press the button. As soon as we press the button, the wire starts oscillating at a very rapid pace. 55,000 cycles per second की speed से wire oscillate करता है, and that disintegrate the stone. So this is one option. We can use carbon dioxide gas to break the stone. We can use holmium laser to break the stone. And once that 12 millimeter stone is broken, maybe in 2 fragments also, then also it is very easy to catch the stone with the Dormier basket, and URS can be done under spinal anesthesia beta. So no need to give general anesthesia. Chalo, now what I'll do is, I'll just revise this entire story once again for you with the eyes closed, which will take half the time. So, because this was the area which I thought is important also, and the examiner might be trying to trap, but I am really confident now that examiner kuch bhi kar le, because you all have the power to think with the open mind and to apply the concepts nicely. So you will be able to deal with such type of questions. Let me also share one small thing with you, beta. What we are seeing in last few exams, maybe in last 2-3 years, when the student comes out of the examination hall, he is not that confident that he has done the exam nicely. But the story is just different after the results. And this time also, I pray to God that students might be having butterflies at this point of time, those who have given the exam, but when the results will come, the results should be good. Between 20 to 30%, this is what I personally feel. And why is it so? ऐसा क्यों है बेटा कि एग्जाम देने के बाद कॉन्फिडेंस नहीं है लेकिन रिजल्ट में अच्छा हो रहा है? That is simply because you are solving 300 questions there. And how you are able to solve those 300? You are using your brain. And when you are using your brain, you might not have heard those questions, all the questions earlier. But because you are using your brain and you have developed these concepts so nicely that whatever answer you are clicking on the computer screen, many a times, if not all the times, but many a times, the answer would be correct, for which the students are not feeling that confidence, क्योंकि they had not seen the similar question with the similar options earlier. तो इसलिए वो confidence level उतना high नहीं होता. अब बेटा हम जो faculties लोग हैं वो क्या करते हैं? हम faculties लोग भी आपसे interact करते हैं. We try to extract कि बेटा क्या पूछा था, examiner was asking this or examiner was asking that, options में क्या था, तो हम लोग आपसे पूछने की कोशिश करते हैं एंड उसके बेसिस पे एक रिकॉल आता है. ठीक है बेटा. अब एक्चुअली में अगर हम देखें, जितने रिकॉल्स ले लीजिए बेटा, they are not going to be 100% what actually was there in the exam. So recall is not an exact recall. It is just an idea. Suppose I am interacting with 5 students and some other person is interacting with 5 students. Now the students with whom I am interacting, I am just trying to put what the information I am getting. But maybe suppose you are interacting with different 5 students, and in those different 5 students, there might be one student who might tell you ki, sir, this option was also there in the question. Now it is not only the question, beta, it is the options also which can change the answer. लाइक हम लोग यहाँ पे यूआरएस RIRS की बात कर रहे थे, है ना? तो इट डिपेंड्स कि व्हाट इज देयर इन द ऑप्शन दैट कैन चेंज द आंसर कंप्लीटली. So it is the student who is appearing for the exam. He is the best judge. What was the question and what answers or what options were there? It is not practically possible for any of the student beta to remember all the 300 questions correctly with the same 300 options, language to language. It's not practically possible, है ना बेटा? तो this is giving butterflies. अब टीचर्स ने बेटा रिकॉल ले लिया. Recall में suppose the language of the question or language of the option is different, and based on what the teacher is showing in the recall, he has marked the answer accordingly. The student who has given the paper, he is seeing the recall and he is getting confused कि यार मैंने तो ये मारा ही नहीं यार, सर तो ये बता रहे हैं, और अगर सर बता रहे हैं तो सर गलत नहीं होंगे. तो ये फीलिंग आने लगती है ना बेटा? तो दैट इज वाई वो जो कॉन्फिडेंस होना चाहिए कि यस मैंने फोड़ दिया पेपर, वो वाला जो कॉन्फिडेंस है ना, वो दिखाई नहीं देता. बट व्हेन द रिजल्ट विल कम, आई डोंट नो, आई एम नॉट अ प्रेडिक्टर ऑफ समथिंग, बट मेरी अपनी एनालिसिस है कि इस बार भी जो ऑल इंडिया रैंक 1 होगा ना, वो 240 से प्लस होगा, 240 प्लस. दिस इज व्हाट आई फील. और बेटा अगर ऑल इंडिया रैंक 1 इज 240 प्लस, तो यू कैन अंडरस्टैंड कि द थिंग्स वुड बी गुड. दिस इज, आई जस्ट प्रे एंड आई होप. ठीक है बेटा? तो नाउ लेट मी जस्ट ट्राई टू कम बैक एंड लेट मी जस्ट ट्राई टू फोकस ऑन द रिविजन. अभी भी ये अच्छा, यहाँ रिजल्ट की चर्चा हो रही है. बेटा देखो, रिजल्ट जो है ना, कल 3 अगस्त, आज क्या है, हाँ कल 3 अगस्त है ना बेटा. 3 अगस्त को क्या है देखें. वेरी गुड कुशमित. नीट पीजी का एग्जाम है ना, तो एनबी तो नीट पीजी में बिजी होना चाहिए. आई होप सो. तो इट माइट टेक फ्यू डेज फॉर द रिजल्ट, है ना बेटा? चलो ठीक है. अच्छा, कल फ्रेंडशिप डे भी है, तो दैट मीन्स सारे पुराने फ्रेंड्स को याद करना है. ग्रेट. चलो बेटा, लेट मी फोकस, नहीं तो मैं आपका ऐसे टाइम खा जाऊंगा. ठीक है. So let's just do a quick revision of this right hypochondrium and the lumbar region story. In the right hypochondrium, gallbladder, biliary channels, pancreatic story, and the liver story. The commonest surgical problem in adults related to gallbladder are the gallstones. These gallstones can either be cholesterol or pigment. Cholesterol stones, they are commonly seen in fat fertile female 40. They are pale yellow in color. And whenever concentration of cholesterol in the gallbladder increases and concentration of bile salt bile acid in the gallbladder decreases, then such bile is called as lithogenic bile or supersaturated bile, and this can lead to precipitation of the cholesterol and form a stone. However, these cholesterol stones can also be seen in abnormal enterohepatic circulation like diseases of terminal ileum, that is tuberculosis or Crohn's disease. In this, because the reabsorption of bile salt bile acid will be affected, so concentration of bile salt bile acid in the gallbladder will be less and cholesterol stones can form. Pigment stones will be seen in those situations where there is more breakdown of RBC, and RBC breakdown from the spleen, the pigment travels into the liver and then into the gallbladder and pigment stones can be seen. Pigment stones can be associated with bacterial infections like E. coli in the gallbladder, or maybe parasitic infestations like Ascaris, Clonorchis sinensis, or maybe even cirrhosis of liver. Whatever it is, whether it is cholesterol or pigment, how gallstone patients can present. More than 80% are asymptomatic, which does not require anything. However, laparoscopic cholecystectomy is done if asymptomatic gallstone, but it is more than 3 centimeter in size, or there are multiple stones, or in elderly people, or immunocompromised, or pregnancy, or typhoid carrier, or maybe porcelain gallbladder, adenomatous polyp more than 10 millimeter in size, hemolytic disorders, bariatric surgery patients. Symptomatic gallstones can present in OPD or in emergency. In OPD, generally patients have mild pain off and on in the right upper abdomen. Clinical examination is not conclusive, so we do an ultrasound of the abdomen, which is the gold standard investigation for gallstone, because gallstone does not have calcium, so they are not seen on X-ray. Gallstone has cholesterol. On ultrasound, gallstone appears hyperechoic, and with the post-acoustic shadow, we can surely say that this is a stone inside the gallbladder. X-ray or CT is a useless investigation for gallstone because there is no calcium. The stones which are not seen on X-ray, remembered by the mnemonic PG Lux, PG में जाएंगे, Lux से नहाएंगे, parotid, gallbladder, lysine, uric acid, xanthine, urinary stones. Symptomatic gallstone, treatment would be elective laparoscopic cholecystectomy. Symptomatic emergency story with gallstone, when a large gallstone is obstructing the mouth of the gallbladder, the mucus gets collected in the gallbladder, stasis party, acute cholecystitis, sudden severe pain in the right hypochondrium, radiating to the back, sometimes to the tip of right shoulder, but more often to the inferior angle of right scapula in the lower back. There may be anorexia, nausea, vomiting, fever. We stabilize the patient in emergency. We do ultrasound and we diagnose acute cholecystitis. HEDA scan is not the investigation of choice to diagnose acute cholecystitis. It is the investigation of choice to differentiate the cause of acute cholecystitis, whether it is acute calculous cholecystitis or it is acalculous cholecystopathy. In HEDA scan, if there is non-visualization of the gallbladder, then it is acute calculous cholecystitis. But if there is persistence of isotope within the gallbladder despite washout of the isotope from remainder of the biliary tree, then it is acalculous cholecystopathy. In acute cholecystitis, there is a possibility that because of acute inflammation, there may be adhesions of the omentum or maybe other structures like transverse colon, stomach, duodenum with the gallbladder. So doing a laparoscopic cholecystectomy in this situation may cause injury to the surrounding structures. So it is better to follow a conservative treatment, admit the patient in the hospital, give IV fluid, IV antibiotics. Within 5 to 7 days, the infection gets controlled, patient becomes fine. We discharge the patient from the hospital with the advice that once the adhesions settle, may take 3 to 6 weeks time. So patient has to come back to the hospital and get her gallbladder removed after 3 to 6 weeks, which we call as interval cholecystectomy. Whenever we are doing laparoscopic cholecystectomy, we make 4 ports in the abdomen. The first around the umbilicus, where we cut the skin, subcutaneous tissue, and put that Veris needle through which we put carbon dioxide gas and create a pneumoperitoneum, so that anterior abdominal wall is lifted up, which help in easy maneuverability of the instruments inside the abdomen. We do the dissection in the hepatobiliary or hepatocystic triangle, which is bounded superiorly by the inferior surface of liver, laterally by the body of gallbladder and the cystic duct, and medially by the common hepatic duct. Content is the cystic artery and the cystic lymph node of Lund. This should be differentiated from Callett's triangle, where superior boundary is the cystic artery and not the inferior surface of liver. So cystic artery will not be the content of Callett's triangle. Cystic lymph node of Lund can be a content of Callett's triangle. When we are doing laparoscopic cholecystectomy, there can be complications. For example, if some gallstones have slipped into the CBD which were not recognized at the time of operation, it can create a biliary obstruction. in the bile duct. Proximal pupil may dilate, pressure in the proximal pupil may increase, which can dislodge the clips on the cystic duct stump, and cystic duct stump may start leaking. If it is just a small leak, then patient may not be having any problems. We can simply do ERCP and stenting. When we put the stent into the CBD, then the bile will start flowing through the lumen of the stent into the duodenum. No leak of bile from the cystic duct stump, and that cystic duct stump will heal spontaneously. If there is a significant leak from the cystic duct stump, a good amount of collection in the subhepatic space, stasis, party, pain, right hypochondrium, fever. Now, if there is party going on in the subhepatic space, there is a risk this can spill in the peritoneal cavity, can lead to peritonitis, septicemia, shock, and patient can even die. So, the most important thing would be drain this collection and localize collection of pus anywhere inside the body, ultrasound guided catheter drainage. Now, needless to specify the role of antibiotics here. We can also do ERCP and stenting. If the cystic duct stump closes spontaneously, wonderful. If not, we have to do a revisional surgery or maybe corrective surgery after some time, maybe 2 months or 3 months time. Sometimes biliary strictures can also occur post-laparoscopic cholecystectomy. There are few other conditions related to gallbladder: mucocele, mucus distension, empyema, pus inside the gallbladder, tube cholecystostomy, cholesterosis of the strawberry gallbladder, yellowish flakes deposit on the mucosal surface of the gallbladder, porcelain gallbladder, calcium, high risk of cancer seen on X-ray, meresis, jaundice due to compression of common hepatic duct by a large gallstone, fistula of gallbladder, most commonly with the first part of duodenum, cholecystoduodenal fistula. Gallstone can slip through the fistula into the duodenum, can create traffic jam in the distal ileum, intestinal obstruction due to gallstone ileus. If we take a X-ray, we can find regular striate, multiple air fluid levels, hair in the gallbladder, stone in the intestine, and the treatment will be removal of the obstruction. If the gallstone slips into the CBD, that is choledocholithiasis, or if the stone forms in the CBD, maybe because of bile duct infection, it can create a partial traffic jam or a complete traffic jam in the bile duct. Partial traffic jam, intermittent jaundice. We do LFT, ultrasound, but to see the biliary channels, MRCP. If examiner has already given that there is a stone in the CBD, then we have to do some therapeutic procedure. Whenever we have to do any diagnostic therapeutic procedure, then we prefer ERCP. So to remove the CBD stones, we do ERCP, sphincterotomy, and CBD stone extraction with the help of a Dormia basket. If there is a complete traffic jam in the CBD, proximal pupil dilated, biliary collection, stasis, party in the CBD is a party whole night. So patient presents this sudden severe pain in the right hypochondrium, high-grade fever, chills and rigors, jaundice, Charcot's triad, Charcot's pain, fever, jaundice. If this party goes into the blood, septicemia, patient goes into septic shock. That is, pressure in the pipeline goes down, hypotension, oxygen supply to the vital organs like brain goes down, mental confusion. Pain, fever, jaundice, hypotension, mental confusion, Raynaud's pentad. If the patient is in shock, pressure in the pipeline is less, first we have to save the life of this patient. So we give IV fluids. And needless to specify, we have to give IV antibiotics. Once the patient becomes stable, we do quick LFT, we can do ultrasound, and because the party in the CBD is a dangerous party, so just giving IV antibiotics may not take control of such a big party. We have to reduce the septic load, so we do endobiliary stenting, that is ERCP and stenting. And once this emergency is sorted, then later on we can do something like ERCP, sphincterotomy, and Dormia basket extraction. When we are doing this ERCP, if it is very easily possible for us to remove the stone also, we can do that and then put a stent in the CVT. If the stone slips into the mouth of the pancreatic duct, it can cause acute pancreatitis. which is basically acute inflammation of the pancreas characterized by sudden onset of severe abdominal pain, shock, and raised pancreatic enzymes. The commonest cause is gallstone. The second commonest cause is alcohol, children, hereditary trauma. Operative cause ERCP. ERCP can cause pancreatitis. Acute pancreatitis can also cause cholangitis rarely. In complete traffic jam of the pancreatic duct, the pancreatic enzymes are not able to go into the duodenum. So pancreatic duct gets dilated and these enzymes get prematurely activated within the pancreas. And these enzymes start digesting the pancreas, necrosis of the pancreas, which will cause acute inflammation, rubor tumor, calor, dolor. Pancreas will become red, hot, inflamed, swollen, sudden, severe pain in the central upper abdomen, radiating to the back either from the right side or from the left side, aggravated in supine, relieved on sitting and bending forwards. Anorexia, nausea, vomiting. Fever is not an early feature because it is enzymatic party, not bacterial party. In this situation, there is huge amount of fluid sequestration also. So we find huge amount of fluid loss from the intravascular to the extravascular spaces, third space collections. We can find ascites, pleural effusion. Because there is huge amount of fluid loss from the intravascular space, the volume in the pipeline goes down, pressure in the pipeline goes down, oxygen supply to the vital organs goes down, patient can die. So this is a serious situation. Tachycardia, tachypnea, hypotension. When party is going on in the pancreas, if the blood vessels are getting eroded, acute hemorrhagic pancreatitis, this blood from the retroperitoneum can trickle and come anteriorly. And if we find a bluish discoloration in the flanks, Gray Turner sign, bluish discoloration around the umbilicus, Cullen sign, bluish discoloration in the inguinal region, Fox sign. And further down it is the Bryant sign. If the patient is in shock, first we have to save the life. So first thing to save this life will be IV fluids. No need of prophylactic antibiotics because it is not a bacterial party, it's a enzymatic party. If we are suspecting acute pancreatitis, we can assess serum amylase and serum lipase. Amylase start rising immediately, remains elevated for 3 days. But it is non-specific. It can rise in other acute abdominal conditions like acute cholecystitis, perforation peritonitis, mesenteric ischemia. However, if the value of amylase is more than 3 times the normal, it favors acute pancreatitis. Serum lipase is specific for acute pancreatitis, but it starts rising after 3 days, though it remains elevated for 12 days. Olden days, when we were doing x-rays, we could have found colon cutoff sign, sentinel loop sign, and renal halo sign. If there is any doubt about acute pancreatitis, then we can take the help of CT scan, which is that radiological investigation of choice where we can do CT Balthazar grading for the severity of acute pancreatitis. But it is done only if we are not able to make the diagnosis. Once the diagnosis is made, then we do ERCP, sphincterotomy, and pancreatic duct stone extraction with the Dormia basket. As soon as you clear the traffic jam in acute pancreatitis, all the enzymes will start flowing back into the duodenum and the story settles. Surgery is not required in acute pancreatitis. However, surgery has to be done if there are any complications like pancreatic abscess or sometimes in pseudocyst. If there is abscess developing around the pancreas, localized collection of pus around the pancreas, ultrasound guided catheter drainage under ultrasound or CT guided percutaneous drainage of this pancreatic abscess with the catheter. Pseudocyst, if the traffic jam in the mouth of the pancreatic duct is there, then proximal pancreatic duct will be dilated, pressure in the pancreatic duct will be high, which can cause rupture of the pancreatic duct, leakage of pancreatic enzymes around the pancreas, neutralized by the fluid, so collection of enzymes fluid around the pancreas. This collection is not lined by any true epithelium. So it is not a true cyst, it is a pseudocyst. Generally, as soon as we clear the traffic jam at the mouth of the pancreatic duct, all this collection around the pancreas goes back into the pancreatic duct and into the duodenum, and these cysts disappear. Usually they are small, patients are asymptomatic, and they resolve spontaneously. If traffic jam at the mouth of the pancreatic duct persists, then this collection around the pancreas may keep on increasing, and sometimes these pseudocysts become so large that they can go up to the mediastinum above and the pelvis below. And this can create pressure symptoms like epigastric pain. Because enzymes are not going into the duodenum, there is malabsorption. These pseudocysts may get infected, abscesses can form which can rupture, but malignancy will never be seen in pseudocysts because there is no true epithelium. Investigation of choice is CT scan. If the patient is symptomatic or there are complications or if it is present for more than 12 weeks, then we do internal drainage of this pseudocyst into the intestine so that enzymes, pancreatic enzymes can go in the intestine. This is cystoenterostomy, which can either be cystojejunostomy or cystogastrostomy. Because of high mortality risk in acute pancreatitis patients, we doctors have to use various prognostic scores to assess the severity of acute pancreatitis and to understand about the prognosis and explain to the patient relatives. A quick SOFA score, Q-SOFA score, respiratory rate 22 or more than 22 per minute, systolic blood pressure 100 or less than 100 millimeter of mercury, altered mental status Glasgow Coma Scale less than 15. If 2 or more than 2 are positive, this indicates severe sepsis. Detailed SOFA score, sequential organ failure assessment, where we assess 6 systems: CNS, CVS, respi, liver, kidney, hematological, each system scoring 0 to 4. Renson's, Apache 2, these are the scores which can be used. Mortality rates in mild acute pancreatitis less than 1%, but severe necrotizing pancreatitis 20 to 50%. Chronic pancreatitis is a chronic, irreversible cellular atrophy of the pancreas associated with calcification, stricture, and ectasias in the pancreatic duct. Most common cause is alcohol, second gallstone. Seen after 40 years of age, 4 times more common in males. People who are drinking for long years or who are smokers, they tend to be dehydrated. So secretions of different glands in the body, they lose water and they become thick. And these thick secretions, when they're traveling in the duct, can create partial traffic jam at different places in the duct and can lead to problems. Like if this is happening in the pancreatic duct, there will be multiple dilatations seen in the pancreatic duct, which will cause back pressure on the pancreatic cells. So both exocrine and endocrine cells will get atrophied gradually in due course of time. If exocrine is getting atrophied, the enzyme secretion will decrease and there will be malabsorption. If endocrine is getting atrophic, 75% are beta cells, insulin production will decrease, blood glucose will increase, hyperglycemia, diabetes mellitus. And in these patients, at the time of meals, whatever exocrine cells are working, they will produce the enzyme goes into the duct, but enzymes cannot easily go into the duodenum. So there will be more congestion within the pancreatic duct, especially after meals, which will cause epigastric pain aggravating after meals. We can do ERCP, MRCP in chronic pancreatitis, which shows chain of lakes appearance. For treating malabsorption, we give pancreatic enzyme supplements like pancreatoflat or creon tablets. For diabetes mellitus, we can give insulin injections. And to solve the epigastric pain aggravating after meals, we advise the patient to stop alcohol completely, to take small, frequent meals. We can give analgesics before meals or octreotide before meals, which is known to reduce the congestion in the pancreas. If nothing is working out, then the last resort is surgery, where we have to connect the dilated portions of the pancreatic duct with the jejunum. That is side of the pancreatic duct connected to side of the jejunum, side to side pancreaticojejunostomy or longitudinal pancreaticojejunostomy or a modified Postos operation. Liver abscesses can be pyogenic, amoebic, or the hydrated cyst. Pyogenic, the bacteria stories Streptococcus malaria E. coli. Amoebic by the protozoa Entamoeba histolytica, and hydrated cyst by the parasite Echinococcus granulosus. Now, pyogenic, whenever there is infection in the bile duct, then this can lead to pyogenic liver abscesses. Patient will have high-grade fever, chills, rigors, and high risk of septicemia, may be associated with pain in the right hypochondrium and sometimes even jaundice. Pyogenic can be single or multiple abscesses. Amoebic is usually single, hydrated is usually single. Amoebic and hydrated, they can present with maybe fever or sometimes even jaundice, pain in the right hypochondrium. But that fever is not high grade in amoebic and hydrated usually, unless there is secondary bacterial infection. In amoebic and hydrated, because there is fecal-oral transmission, so whether it is the midgut or the hindgut story, the story will come through the superior inferior mesenteric vein, portal vein, liver. And that is how these liver abscesses can form. In amoebic colitis, we find inverted flask-shaped ulcers in the sigmoid colon. Now, if the patient is having pain in the right hypochondrium, we do ultrasound. If the patient is having jaundice, we do ultrasound can show us the abscess inside the liver. Better than ultrasound to show these abscesses in the parenchyma will be CECT. In hydrated cyst, whether we are doing ultrasound or CECT, we can see a water lily sign. And in hydrated, we can do a Garvey classification for grading the hydrated cyst. If it's only liquid, it is grade 1. Water lily is grade 2. Honeycomb 3. Heterogeneous 4. Calcified 5. Suppose when we are doing ultrasound or CT, we are just seeing an abscess inside the liver and we are not sure whether it is pyogenic, amoebic or hydrated. To confirm that, we can do a blood culture, pus culture, which can give us the diagnosis of pyogenic, stool test to detect the ovocyst of entamoeba for amoebic, and ELISA to detect antibodies against the hydrated antigen for hydrated cyst. Once the diagnosis is made, if it is pyogenic, we have to give broad spectrum antibiotics to target gram-positive, gram-negative and the anaerobes like penicillin cephalosporin group plus aminoglycosides plus metronidazole. For amoeba protozoa, metronidazole, which is given in a double dose 400 to 800 milligram 3 times a day for 14 days. For hydrated cyst, we give albendazole or mebendazole. If the abscess is large and the risk of rupture is there, then ultrasound guided pigtail catheter drainage has to be done. In hydrated cyst drainage, we have to be extra careful because there is risk of dissemination of the disease. So we use a special technique pair, that is percutaneous aspiration, installation of hypertonic saline to destroy any live activity inside the cyst, and then re-aspiration. Sigmoid volvulus, though sigmoid colon is in the left iliac fossa. But sometimes if the mesentery of the sigmoid colon is long, it can rotate in anti-clockwise direction so that apex of sigmoid goes towards the right hypochondrium. On X-ray, we can see a coffee bean sign, bird of prey sign, and the treatment is just putting a fletus tube in the sigmoid colon for 24 hours, which will empty the sigmoid colon, following which it can derotate and come back in its original position. If by chance, because of this volvulus, the sigmoid colon is strangulated or gangrenous, then we have to do resection and anastomosis. For urinary stones in the lumbar region, kidney, ureter, bladder, urethra stones, most common kidney stone is calcium oxalate and dihydrate, whether it is adult or a child. Most common urinary bladder stone which are seen in boys, it is calcium oxalate and urate stones, ammonium urate stones. Uric acid stones are more commonly seen in adults in the urinary bladder. Urinary bladder stones are 10 times more common in boys. Reasons for these urinary stones, most common is idiopathic hypercalciuria. Anybody who is passing more calcium in urine, there are chances this calcium may get deposited somewhere in the urinary mucosa and gradually crystals will get deposited over it and form a stone. However, idiopathic hyperoxaluria, uricosuriia, cystinuria, all these can be causes. Prolonged immobilization, which reduces the motility, or peristalsis, can lead to stasis infection, UTIs. Cranberry juice prevents UTI. Deficiency of vitamin A, hyperparathyroidism, milk alkali syndrome, all this can cause urinary stones. The different type of urinary stones: calcium oxalate, which can be monohydrate, dihydrate. Monohydrate is the second hardest, dihydrate is the most common. Envelope shaped crystals are seen. These calcium oxalate are speculated, so risk of hematuria. Triple phosphate stones: calcium, ammonium, magnesium phosphate, also called as true white. They are seen in alkaline urine when urine gets infected with urea splitting bacteria like Proteus and maybe Klebsiella. These stones usually remain silent. They may take the shape of the pelvic ileal system, which is called as staghorn stone. Uric acid stones seen in patients of uricosuriia, acidic urine, and these do not have calcium. They are radiolucent. They are not seen on X-ray. Stones which are not seen on X-ray, PG में जाएंगे, लग से नाएंगे. Parotid gallbladder, lysine, uric acid, xanthine. Cystine stones are the hardest stones which are difficult to be broken by shock waves, and we can find benzene or hexagonal crystals. Cystine stones, they are the hardest stones and seen in patients of cystinuria. We can find lysine, xanthine, indianavir, triamterene, allopurinol, all type of stones in the urinary tract. Whatever is the stone, how will the patient present? Most common presentation is pain. There can be frequency of micturition. There can be hematuria. There can be interruption of urinary stream due to large vesicle calculus. Pain, the location or the site of pain depends on the location of the stone. If the stone is in the kidney, there is fixed lumbar pain. Upper ureteric stone, lumbar pain radiate to the perineum in females and testis in males. Pelvic brim stone, that is at the junction of upper middle ureter, lumbar pain radiate to inner thigh. Middle ureteric stone, lumbar pain radiate to the corresponding iliac fossa, like if it is right middle ureteric stone, mimics acute appendicitis. Lower ureteric stone or intramural ureteric stone, strangury, painful desire to pass urine with passage of few drops of urine and rarely blood. Bladder stone does not present with lumbar pain, it presents with suprapubic pain. If the bladder stone comes at the bladder neck or in the urethra, suprapubic pain is referred to the tip of penis. When these patients come to us in emergency, because they are in severe pain, so first we have to relieve their pain, diclofenac, tamsulosin. 80 to 90% of urinary stones have got calcium, so we can see them on X-ray and CT scan nicely. We can do a plain X-ray KUB and we can see these stones. However, best investigation would be non-contrast CT scan. Don't give contrast to see the urinary stone, because contrast stone and stone have got the same density. So stone may not be seen in a contrast enhanced CT scan. So we prefer non-contrast CT. In the treatment, if the stone is up to 5 mm in size in the urinary tract, because the diameter of urethra is 6 to 8 mm, up to 5 mm stones, 90% can pass spontaneously in urine with just plenty of fluids. 6 to 10 mm size stones, 90% of stones can pass spontaneously. However, more than 5 mm stone, if it is in the kidney, upper ureter, middle ureter, treatment of choice is ESWL. Lower ureteric stone, treatment of choice is URS, that is ureteroscopic retrieval of stone using Dormia basket. Bladder stone, treatment of choice is Lithola Pexi using a cystoscope. And urethral stone, we have to push the stone back into the bladder through a cystoscope and treat it like a bladder stone. If for kidney stones, the ESWL is not possible, maybe because the stone size is more than 2 centimeter, or it's a cystine stone or pregnancy or bleeding disorders or any distal obstruction, then we do a RIRS, retrograde intrarenal surgery. If the kidney stone is more than 2 centimeter in size, we prefer doing a PCNL, percutaneous nephrolithotomy. When we are doing ESWL, extracorporeal shockwave lithotripsy, the shock waves are fired directly onto the stone, which break the stone into small fragments, and these fragmented stones align themselves in the ureter like a street of stones, which is Steen-Strass phenomena. Most common complication of ESWL is bleeding, and it is avoided in stones more than 2 centimeter in size, pregnancy, bleeding disorders, cystine stones, and distal obstruction. Retrograde intrarenal surgery, that is indicated for stones less than 2 centimeter in size in the kidney, especially if ESWL is not possible, like in obese individuals, musculoskeletal disorder patients, or bleeding disorder patients, or lower pole or lower calyx stone in the kidney. PCNL is percutaneous nephrolithotomy. Most common complication is bleeding. It is done through 12th rib approach. There is risk of injury to the pleura, colon, spleen. There is risk of hemothorax, hydrothorax, but lung injury is not seen usually in PCNL. If we are doing any endourological procedures in the upper urinary tract, that is ureter and kidney, whether we are doing URS or we are doing RIRS or we are doing ESWL or we are doing PCNL, we should place a double J stent in the ureter so that fragmented stone may not get arrested anywhere in the ureter. It should pass down. And whenever double J stent is there inside, because it's a foreign body, if we don't remove it, it can create complications in the patient. So ideally we should remove it within 3 to 4 weeks or 3 to 6 weeks time. And to remove this double J stent, we just have to put a cystoscope into the bladder and hold this double J loop and take the entire assembly out. If it's an emergency urinary obstruction, depending on whether it is the upper urinary tract or lower urinary tract. Suppose it's upper urinary tract, ureteric obstruction, proximal people getting dilated, hydroureteronephrosis, maybe pyonephrosis, we try to do a endourinary stenting, double J stenting. If we are not able to negotiate the stent across the obstruction, then we do PCN, percutaneous nephrostomy. If it's a lower urinary tract obstruction like in urethra leading to retention of urine in the bladder, then we try doing a Foley's urethral catheterization from below. If we are not able to pass the catheter across the obstruction, then we do suprapubic cystostomy using a supracath. Urinary tuberculosis. This is not an ascending infection, it's a hematogenous infection. The mycobacteria are traveling from the lungs towards the kidney, and initially this causes ulcer at the renal papilla, and gradually this part involves the entire kidney, causing putty kidney, which can transform to cement kidney, which can break. Autonephrectomy can occur. In bladder TB, initially the changes are seen around the ureteric orifice, gradually involve the entire bladder, narrow contracted bladder, thimble bladder. Patient presents with frequency of micturition, sometimes hematuria. There would be anorexia, weight loss, low-grade evening rise of temperature. When we do urine examination, early morning, first urine sample, midstream sample is taken, and if it shows sterile, acidic pyuria, it gives a high suspicion of tuberculosis. We can do CECT, or if we are doing IVP, in renal tuberculosis, early stage, we find moth-eaten calyces or indistinct calyces. Late stages, we find pseudocalculi appearance. In bladder TB, early stages, goal-fold ureteric orifice. Late stages, thimble bladder. And the treatment is anti-tubercular therapy. Thank you very much for your patience. Right. We'll take a break here and we'll be back at 4:35 p.m. And a new video would be coming up. Right. Let me just have a look. I know, beta, I'm taking a lot of time in doing these revisions, but I just hope that probably whenever today we'll be continuing up to 8 o'clock in the evening, beta, Pushkar. Today I got the opportunity to meet Kunal sir. Right. Okay, beta. If you are comfortable, beta, it's great. Wonderful. Let's take a break.